Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our panel of experts. 1 in 3 women will experience a pelvic floor disorder or PFD in her lifetime. PFDs occur when women have weakened pelvic muscles or tears in the connective tissue, which may cause bladder control problems, bowel control problems, or surrounding pelvic organs to fall into the vagina and cause pelvic organ prolapse. Jefferson Health's comprehensive female pelvic medicine and reconstructive surgery multidisciplinary team specializes in the diagnosis, management, and treatment of PFDs from conventional to complementary medicine. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the panelists are all submitted right from when you registered for this webinar. And if you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you will see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you're experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Well, without further ado, I want to go ahead and introduce our experts for the evening, and we'll have you just go ahead and introduce yourself. So let's start with Dr. Whitney Smith with urogynecology and urology. How are you doing, Dr. Smith? Welcome.
I'm doing well. Thank you for having me. I am Whitney Smith. I'm one of the urologists, and I also practice urogynecology. I mostly see patients at our Abington location, although I also see patients in our South Philly Navy Yard location. I specialize in pelvic floor disorders such as urinary incontinence and pelvic organ prolapse in women. And I'm excited to be here and talk with you guys today.
Great. Well, thank you so much. We're excited to have you here. All right. Well, Rachel Roswald, we will turn to you now. PT, DPT with pelvic floor physical therapy. Great to have you, and let's have you introduce yourself.
Hi, thanks so much for having me. I'm really excited to get to all these questions. I am located out of Abington, Jefferson. Started the program there in about 2020, and just love helping everybody overcome these pelvic floor disorders. So we're excited to get to it.
Great. All right. Well, then let's go ahead and dive into the questions because I know we have a lot to get to tonight. So without further ado, the first question for you, I will turn to Dr. Smith. What are the first symptoms of a pelvic floor disorder and incontinence?
So that's a great question. It can really vary because there's so many pelvic floor disorders and there's a spectrum. So some examples include leaking of urine with laughing, coughing, sneezing, or physical activity such as running or jumping. Failure to reach the toilet in time when it comes to urination or having accidental bowel movements. Feeling a bulge in the vagina, like something is falling out or hanging out, or sometimes women can see a distinct bulge in the vaginal area, as well as having pain or different sensations in the vagina or on the vulva, which is the outer portion of the female genitalia. Painful sex can also be a sign of a pelvic floor disorder, and having recurrent urinary tract infections. So all of those things can signal the start or having a pelvic floor disorder.
Okay. Well, thank you very much. All right, Rachel, we will turn to you for the next question. What are some at-home exercises patients can do to help with and prevent pelvic floor disorder? We particularly received a lot of questions about Kegels. So can you talk about them and do they work?
I would love to address this. So when we think about the pelvic floor disorders, we often see either Overactivity, so really over engaged, painful muscles that can be shortened and therefore not efficient in what they're trying to do, stop your urine, provide you with less pain. And we also see underactivity, so a pure weakness or discoordination of the pelvic floor. When you have a pure weakness issue, this can be a helpful way of doing a pelvic floor contraction, or what most people consider a Kegel. However, if you have an overactivity where the muscles are overengaged or trying to do too much and they're unable to fully elongate or to relax post-contraction, doing a Kegel can actually be the opposite effect. It can make everything that you're experiencing a little bit worse. So we always encourage anyone that comes in, we'll do a full assessment, we'll see which of these two pathways you're currently on. And at home, a good way of starting to get kind of the basic understanding back into the brain and back into the muscles of the pelvic floor is to start by some easy diaphragmatic breathing. What we want to have happen is for your lungs to really expand and to lower down into the chest cavity with the diaphragm. As that happens, anatomically, your pelvic floor should be relaxing, and conversely, when you blow out your air, your pelvic floor should be contracting. So that's a nice, easy way of getting that full elongation and the full relaxation that anyone can do at home, as well as a nice contraction. So we often will encourage everybody to start with breathing. I know that Kegels are a hot button topic, especially right now on social media. We always caution everybody, there's not a one size fits all exercise. It's not going to fit everybody, but it can be a really nice way to start. And we always progress you from doing a pelvic floor contraction to more functional activities, squatting, lifting, moving, along with the appropriate coordination of these muscles.
Okay, well, thank you. And it's helpful to hear that distinction. So thanks for walking us through that. All right, Dr. Smith, we will turn back to you. Can you talk a little bit about some surgical and non-surgical options for patients?
Yeah, so when it comes to non-surgical options for pelvic floor disorders, it's important to kind of distinguish that there's many pelvic floor disorders. So some things, working with a pelvic floor physical therapist. And we do find that while you can do some of these exercises at home, we do find oftentimes there is enhanced benefit by working with someone like Rachel with guided pelvic floor physical therapy. I spend a lot of time with my patients kind of optimizing certain medical conditions or associated conditions, such as constipation. So improving your diet or adding things like fiber to help soften the stool can be very helpful. Other dietary modification, avoiding bladder irritants, which can exacerbate an overactive bladder. Quitting tobacco, because that can also be a bladder irritant. Behavioral modification, so sometimes going to the bathroom to pee or to have bowel movement kind of on a schedule can be helpful when it comes to things like overactive bladder or anything like that. Weight loss, which can be very helpful. Losing weight can be a struggle, but we found that even with small amounts of weight loss, maybe 5% of total body weight can result in about 50% reduction in urinary incontinence episodes. So I do recognize that it can be a struggle, and fortunately Jefferson has a comprehensive weight management program where you can meet with experts, even telehealth or in person, for surgical and medical weight loss. And we have a lot of patients that we refer to them. Optimizing position on the toilet, so using things like so making sure you're sitting all the way down on the toilet, no hovering, and using a squatty potty can help optimize toileting positions. Improving the vaginal tissue quality with lubricants and low-dose topical vaginal estrogen. And in the office, we can do things like percutaneous tibial neuromodulation for overactive bladder. And that's a squatty potty that you can see on the screen, or a squatting stool, I should say. It can raise your legs while you're on the toilet, which can make it easier to have bowel movements and sometimes make it easier for patients to empty their bladder. So when it comes to surgery, when we think about each one of the conditions, so for prolapse, there's kind of two flavors. There's abdominal surgery, typically done laparoscopically with the assistance of robotics to do reconstruction of the vagina, as well as vaginal surgeries. And these surgeries can be done sometimes with or without removal of the uterus. And there are some options that we use that do not utilize mesh. So there's some nuances to both, and someone may not be a candidate for both, for both of them. So it will be important to kind of get a sense of what works for you. When it comes to incontinence, there are things like urethral bulking, which is kind of like filler for the urethra. There's slings, whether mesh-based or using your own tissues. So those are some options for urinary incontinence. And then with fecal incontinence, which is also pretty common, that can be a little bit tricky because sometimes, reconstruction of the anal sphincter may not be the answer, or maybe it is. Things like sacral neuromodulation, or sometimes we have the assistance of our colorectal surgeons who weigh in because sometimes something, like a colostomy may be an option. So there's many different options.
Right. Well, thank you. Yeah, it's great to hear that there are so many different options. So thanks for outlining that. I guess as a follow-up there, for the surgical options, are any of these options a cure?
So that's I will say a difficult question to answer because I oftentimes tell my patients, especially with things like prolapse, that it can be a chronic condition because it's kind of a weakening of tissues, and there's a chance that prolapse can come back. And each procedure, when it comes to prolapse, does have a success rate and also a failure rate. But for many people, it can be a cure and can be an option for them to not need like a pessary or something like that. Same thing when it comes to urinary incontinence, especially stress urinary incontinence. These treatments can be a cure. There is a failure rate, a chance that it may come back, and sometimes multiple things need to be tried, but it can be a cure for some women.
Okay, great. I think that's great news. And can you also just talk a little bit about the risks and maybe recovery time for these options too?
Yeah, again, kind of varies based off of the condition and what we're doing. I generally tell for my patients who are undergoing prolapse repairs, oftentimes recovery is about 4 to 6 weeks. A lot of that has to do with the restrictions afterwards, especially when it comes to things like lifting. Sometimes surgery can be painful as well. So having some downtime is going to be very helpful. So those are kind of the main restrictions that lead to that 4 to 6 weeks when it comes to prolapse surgery. And that's whether it's vaginal surgery or abdominal surgery for prolapse. Similarly, for incontinence, there are some minimally invasive options, such as sling or urethral, a mesh-based sling or urethral bulking. There is some downtime, but with urethral bulking, oftentimes women are okay going back to work, sometimes even the next day. And there's, pretty much no restrictions with that. With the sling, there's a little bit more. So I generally, 2 to 4 weeks. So it kind of really varies. Overall, surgery is safe, but there are some potential risks, and it kind of varies by person. But overall, these options are very safe.
Okay. All right. Well, thank you so much, Dr. Smith. Rachel, we will turn to you for our next question here. After Botox for pelvic floor, along with physical therapy, do trigger points go away or does pain return?
Great question. So Botox for trigger points is a little bit newer of a use of Botox, especially in the pelvic floor realm. We have seen some patients who have great success 1 round, they do really well, the muscles relax, they feel better. And others have had to go back for a series of injections. We do continue therapy throughout, we always like to think about addressing the underlying functional changes that the whole body is experiencing as a result of the original trigger points and the pelvic pain often that people are experiencing. So still focusing on the other muscle systems around the pelvic floor to get everything else and the burden of like the pain and kind of the neuro treatment that we can do to help resolve your pain as you're going through this with the Botox can be super helpful. So we've seen kind of both ways, patients who do great one time, patients who need to go back for a series of injections, but either way, it can be a nice tool to use.
Absolutely. And Dr. Smith, anything you'd like to add there?
Just like Rachel said, it's kind of a newer thing. Sometimes, it hasn't really been standardized. So, it's difficult for us to give, expectations because we don't have a standardized template for doing Botox into the pelvic floor. So really outcomes can vary, and we also don't have great evidence for it. And sometimes it can be difficult to be covered by insurance because they sometimes may view it as being experimental. But there are some people who have great success with it, people who have been doing it routinely. So it really kind of depends on the individual and expectations. But hopefully in the future that can be something that's well studied and researched, and we can have standardized protocols for it.
Okay, thank you. All right, let's talk a little bit about weight loss now. Rachel, question for you here. Does weight loss help alleviate the symptoms and pain associated with the PDF and incontinence?
So like Dr. Smith was saying, weight loss is a great way of helping alleviate some symptoms for patients with pelvic floor dysfunction. When you come to physical therapy for the first time, we do a whole comprehensive look similar to Dr. Smith. We take a look at your hydration, your constipation. What is your diet doing for you? What is your activity level? How is everything forming this whole picture of a person that we see in front of us? So what we like to do is to then, as you're going through your weight loss journey, focus on what muscles can we help keep strong? How can we help you get a little bit more movement in your daily life? How can we change your routine? How can we help you be the most successful so that we have a better outcome pelvic floor wise? So similar to Kegels, we kind of remind everybody that losing weight or doing one exercise is a great way of starting and is a tool, but we don't recommend that you put all of your reliance on one thing. And to keep strengthening everything you can, keeping the flexibility, keeping that muscle activation really well throughout the day for functional mobility is just as important as the initial weight loss. And we really try to support you in whatever way we can on your weight loss journey. It is a challenge for sure.
Yeah. All right. Well, thank you. And Dr. Smith, anything you'd like to add there too?
Nope, I'd just like to echo all of that she just said.
Great. All right. Well, thank you. Okay, moving along to our next question here. Dr. Smith, this one is for you talking about uterine fibroids. What is the impact on urinary and bowel?
So that's a great question because sometimes it can be confusing when you have multiple issues in the pelvis. I will say in general, usually uterine fibroids and ovarian cysts don't contribute to issues of bowel bladder dysfunction. Usually, there's some rare cases where the fibroids or the ovarian cysts can be hugely space occupying in the abdomen, with them being very, very large. But in general, they usually do not contribute. So if someone does have issues of bowel incontinence or constipation, difficulty having bowel movements, or urinary symptoms, just removal of the fibroids or doing a hysterectomy will not lead to improvement in those conditions. So it can be very, certainly you have to work with your urogynecologist, your urologist, or gynecologist to see, would you benefit from having, those fibroids or ovarian cysts taken care of. Sometimes, some of the treatments, like if you had a hysterectomy, For fibroids, hysterectomy can be a risk factor for pelvic organ prolapse, and radical surgery for radical hysterectomies, like for cancers, and removal of the ovaries, can lead to bowel and bladder issues in those cases. So sometimes the treatments can temporarily or long-term lead to some issues. But in general, the fibroids and ovarian cysts usually do not cause that.
Okay. All right. Well, thank you. All right, Rachel, question for you about UTIs here. Can UTIs make incontinence worse, and can incontinence cause UTIs?
Great question. So we often can see a increase in symptoms with a UTI for sure. We always caution patients, if you have a cold, if you have, in this season, the flu or any respiratory thing, your symptoms can certainly get worse, and to give yourself a little bit of grace. Your body is healing during that time. So go back to your basics. Don't panic if it's happening. And we'll kind of pick up where we left off once you're feeling a little bit better, and often once the antibiotics are doing their job for UTI. Again, incontinence doesn't really necessarily cause a UTI, but we always caution patients to be aware of what is touching your vulva. Bacteria loves damp, dark spaces. So let's make sure our hygiene's on, very accurate during this time. Let's make sure that we're changing pads if we need to often. Let's make sure that we're not giving bacteria a really nice resting place, especially something that's right against your vulva. So as long as you're keeping really nice hygiene during this time, incontinence doesn't necessarily cause UTIs.
Okay. All right. Well, thank you. Okay, moving along here. Dr. Smith, can constipation contribute to pelvic floor dysfunction?
Yes, it actually can. So being constipated can lead to chronic straining, which can lead to weakening of pelvic floor muscles and can cause extra stress on pelvic organs and nerves. In addition, when someone is constipated, you can also have bladder dysfunction. So bowel bladder dysfunction does exist because the bowel and the bladder can oftentimes shares the similar nerve distribution and sensation. So certainly one can contribute to another. In addition, when you have constipation, especially with hard stools, you have abnormal stool consistency, which can then predispose you to having things like accidental bowel leakage or fecal incontinence. So certainly, yes, constipation can lead to various pelvic floor disorders.
Okay. Okay. Rachel, talking here a moment about pregnant women, how can pregnant people preparing for birth strengthen their pelvic floor to avoid, further weakness?
Another good question. So there are lots of things that people who are pregnant can do to keep themselves ready and preparing for birth. One is just keep your activity level up. Birth is definitely a marathon. So you want your body to be able to undergo what it can do, right? So work on your strength, work on your endurance. Even a walk a day is a great way of starting. We always like to encourage you to keep your flexibility up. The mobility of your pelvis, the mobility of your hips is going to be a great positive thing for you while you're undergoing birth in whatever position you choose to give birth in. And there is a misconception out there that the pelvic floor pushes the baby out, and the opposite is true. We really want the pelvic floor to be able to relax and to get out of the way as you're giving birth. So again, one of the great things you can go back to is that nice deep breathing where you're really working towards having that full elongation and that full contraction of your pelvic floor. We encourage anyone who is pregnant to come in and see us. It doesn't matter how far along you are, super early on, super late. We can certainly help on everything from the flexibility and strengthening to practicing birthing positions, practicing your breathing, practicing what is going to go into making your birth the most successful thing it can be.
Okay. All right. Well, thank you. All right. Dr. Smith, we'll get back to you now. I know you mentioned a pessary earlier in our conversation. So here, this question is about that. How long can someone use a pessary for a bladder prolapse?
So for prolapse or incontinence, pessaries can be used indefinitely. They come in different shapes and sizes depending on the patient and what their goals are. And it is an option to be used indefinitely. However, there is some maintenance when it comes to that. Patients can remove the pessaries themselves and clean it, but you should still follow up with your doctor on a regular basis. Or that maintenance can be done by the provider, where patients will come in every 3 to 6 months to have their pessary removed by their provider, cleaned, and have the vagina inspected to make sure there's no things like ulcers or any bleeding from the pessary. Also, when you meet with your provider for your pessary checkups, they'll ask you about any worsening urinary incontinence or any bowel issues, any vaginal discharge or infections, because those may be signs that, the pessary may not be working. In addition, comfort should also be something that the provider asks about, because if a pessary is fit properly for the patient and the patient can is comfortable with it, that means that they can continue on with it, but it shouldn't be uncomfortable. Sometimes women have anatomy where they're not great candidates for pessaries, like a shortened vagina, maybe from prior surgery, or certain high degree of prolapse where it's not comfortable or keeps falling out. But pessaries can be an option, a long-term option for women to manage prolapse.
Okay. All right. Well, thank you. Okay. Before we go on to this next question, I just want to thank the audience. I see a lot of questions coming in the chat, so we'll definitely get to those live questions in just a bit. But here we'll go through a few more submitted questions before we hop to live questions. So for this next one here, Rachel, question for you. How is pelvic floor health impacted in patients who have connective tissue or generalized joint hypermobility?
Patients who are hypermobile can definitely have their own set of unique challenges. We like to really focus on proximal stability, your core, your trunk, your back, making sure that we're focusing a little bit more on the stability, a little less on the flexibility. Obviously, if you're over flexible, especially those with Ehlers-Danlos syndrome, we don't want to hyper move anything. We want to really tone it down, work our way into that stability, that nice safe space for your body to start working from. We often start by reminding everybody the stack, keeping your ribs right over your pelvis, making sure that your core and that your pelvis is engaged correctly so that you have that proximal stability before we work on that distal mobility. And it can definitely be a little bit more focused approach on the conscious maintaining that stability throughout all of the exercises. But we see a lot of patients with these hypermobility issues, and it's always such a joy to treat them.
Okay, well, thank you. All right, Dr. Smith, next question for you here. For someone who has both forms of incontinence, what are recommendations to alleviate symptoms and pain?
Yeah, so it'll be definitely important when you are meeting with your provider to discuss what exactly your symptoms are. Is it just pain, or how much incontinence does the patient have, as well as the degree of bother. So for pretty much all patients that come to see us, they fill out a symptom questionnaire so we can get a sense of how impactful it is on the quality of life. When it comes to ways to manage, certainly our basics are looking at the diet, trying to improve stool consistency through diet, or sometimes medications or supplements are needed. Avoiding those bladder irritants, making sure there's not a urinary tract infection, and things like doing a pelvic exam so we can look for associated pelvic floor disorders. When it comes to procedures, it can be there can be some great options, both surgical and non-surgical, but specifically someone who suffers from accidental bowel leakage, as well as urgency urinary incontinence, sacral neuromodulation, which almost looks like a pacemaker, although it doesn't pace the bowel and the bladder and tell it when to pee and poop. But that can be a great option for someone who suffers from urgency, urinary incontinence, as well as fecal incontinence. So really kind of, getting a good overall picture of what's going on and then kind of going from there.
Okay. And Rachel, anything you'd like to add there?
I think Dr. Smith covers it great. We go over, again, very similar things on our initial visit and then all of our subsequent visits. We can certainly work the positioning, how you're using your muscles correctly on the toilet, all of that good things. We can just work as a whole comprehensive unit to help alleviate these symptoms and pain.
Okay, great. Well, thank you. Rachel, a next question for you here. What restrictions would you recommend to prevent these conditions from reoccurring? Should certain ab exercises or maybe like heavy lifting be avoided?
I'll start by saying we love getting you back to doing the things that you love. If your goal is to go and heavy weight lift or run a marathon or simply lift your groceries up without leaking, then we're going to be with you every single step of the way. We're not typically in the business of saying you're never going to do this thing ever again. We might just have to change how it looks to do it successfully for you, and also how your body needs to be able to be in the right position or the right strength to be able to do the thing successfully. You can find a whole host of misinformation on the internet about how, oh my gosh, never do a crunch, never do a plank, never do blah, blah, blah. We often encourage everybody to don't just go and do it, but come in and we'll learn together how to do it successfully for your body. So there's a lot of pressure management, especially with a person who has a history of a prolapse, that can be super helpful for all of these higher level activities, or even just being able to lift your baby out of a crib. So learning how to manage your body's pressure systems correctly is so important. The biggest rule of thumb I could give you is to just blow out anytime you're lifting anything up, even if it's like a tissue up off the floor. Get into that habit of really releasing your pressure as you're moving. And that can be a really nice step to just start on day one of noticing you have an issue before you come on in and see us about it.
Okay. Sounds like a takeaway is don't let the internet scare you. Come to the experts. Okay. All right, Dr. Smith. Question for you about age limit. Is there any age limit for surgery?
So there's no age limit for surgery, which is good news. And surgery can oftentimes benefit the young and the elderly as well. There's many different options. So something, we take into account someone's overall health, what is their functional status, and any other associated medical conditions like heart problems, lung problems, the need for blood thinners, previous surgeries that they had, especially in the abdomen and pelvis, and what is a person's overall goals. But I've done operations on people in their 20s and 30s, and I've done operations in patients in their 90s when it comes to managing some of these pelvic floor disorders. And there's actually some excellent studies that even in elderly patients, they benefit greatly from having a procedure because it can keep them from, having really bad incontinence that puts them in a nursing home because their family cannot manage it, or it improves their overall quality of life. So, there's no age limit. We just may have to adjust certain things, and some people may be a candidate. Even sometimes younger people may not be a surgical candidate, but there's options for everyone.
Okay. Definitely reassuring to hear. So thank you. All right. So we'll take one more question and then dive into our live audience questions. This last question is for you, Dr. Smith, just talking a little bit about the sling. So for someone who had the sling surgery, some say the incontinence seems to be worsening again. So what are some of their options?
Yeah, so a sling is a procedure that we do for stress urinary incontinence. So that's leakage of urine with laughing, coughing, sneezing, physical activity. And the sling is placed under the urethra. So it's not a bladder sling. A sling is not placed for prolapse. It's placed under the urethra and kind of acts as a seatbelt to give support for the urethra. So why would someone who has this procedure have incontinence afterwards? We really have to kind of get to the bottom of it. Firstly, we have to make sure that there's no complications from the sling. So if it was a mesh-based sling, we need to make sure that that mesh hasn't become eroded into the urinary tract. In addition, we need to see what type of incontinence, because sometimes it can even fool us. So stress incontinence, there can also be urgency incontinence that the patient is now experiencing, because that can be a side effect of having a sling operation where all of a sudden it's like, gotta go, and they may leak, but it may mimic their previous type of incontinence. In addition, we sometimes do testing called urodynamics in cystoscopy to look inside the bladder. So for someone who truly has recurrence of stress urinary incontinence, it could be that they had a previous mesh-based sling that was found in the nowadays to not be as effective, and that sling may not even be used anymore. So it could be a sling that just didn't have great outcomes. Or someone has a failure. Overall, the mesh-based slings have a success rate in the 80s to 90%, so pretty high. But surgical options include bulking, urethral bulking, kind of filler for the urethra. We can also place another mesh-based sling, and we don't necessarily have to remove the previous sling. Or we can do what's called autologous fascial sling, where we use the patient's own tissues harvested from the abdominal wall or sometimes the thigh to create a sling of their own tissues. So there can be options for someone who has recurrence of stress incontinence after they had a sling procedure.
Okay. All right. Well, thank you for going through that for us. And I think with that, we will turn to our live questions from the audience. So with that, I'll go ahead and just start with the first question here. And it looks like this one is for you, Dr. Smith. This person is wondering, what options are there for pain relief and how quickly do they work?
I will say, oftentimes, pain can be difficult to treat quickly. Things like opioid pain medications aren't really very helpful, and it can lead to things like constipation. So it really depends on where is the pain. Is it lower abdomen? Is it the vulva, the skin overlying the female external genitalia? Is it inside the vagina? Is it bladder pain? But things like urinary analgesics, something like azo or pyridium for someone who has burning with urination can work pretty quickly. Certain topical gels that have a pain relieving property to them can be very helpful. If there's something like a urinary tract infection, the answer, we start with antibiotics. I try to do my best to try to work with my patients with certain pelvic floor exercises, things like that. Identifying constipation, hard stools. So it really kind of depends. It can be very frustrating though, because I will say it can be a challenge to treat pelvic pain. But working with your doctor can be very, very helpful, or your pelvic floor physical therapist.
Absolutely. Okay. And with that, Rachel, a second question here for you. Is PT a long process? This person is wondering, what is the average length of time someone is in PT?
So we see a variety. Normally, you'll see your therapist for about an hour, once a week or so. I'll kind of give a wide range. And then on average, I'd say we see everybody between 8 and 12 visits. Some patients are in and out much quicker. Some patients have a lot more complicated history, so they're with us a lot longer. But I'd say on average, about 8 weeks.
Okay, great. All right, next question here. Are women who've had a total hysterectomy at greater risk for pelvic prolapse? Anything that can be done to reduce the risk?
That's a great question. And happy to say that oftentimes not. We are oftentimes doing prolapse surgeries on women who previously had a hysterectomy for whatever reason, whether it be for a history of cancer or for something benign like fibroids. So it's something that's very familiar to the urogynecologist when it comes to doing surgical repairs. And oftentimes women are great candidates for many of the surgical options. And we commonly, for women who still have their uterus, oftentimes we do a hysterectomy as well at the time of. So it's certainly not an increased risk and shouldn't deter anyone. When it comes to things to decreased risk, I would say, making, your physician will do a good head to toe exam. We'll kind of ask you questions about what type of surgery you had, why you had it done, the approach. So if it was a hysterectomy, did they do it through the abdomen or did they do it through the vagina? And what kind of incisions or scars do you have? So was it laparoscopic? Was it an open operation? If there was anything else done, because oftentimes when we'll say, oh, I had a hysterectomy for prolapse, but a hysterectomy alone doesn't fix prolapse. So oftentimes they'll have something else done at the same time as that hysterectomy. So if you have access to your operative note, that can be very helpful for your doctor. So they know exactly what you had done and can help plan a safe operation for you.
Okay, thank you. All right. This next question here, this person is just wondering if you could talk a little bit more about pudendal neuralgia, and apologies if I mispronounced that, but if anyone wants to talk about this, this person is curious.
Yeah, I can talk a little bit about, I will say, certain pelvic pain disorders I'm not a great expert at, but certainly I'm familiar with pudendal neuralgia, which is the pudendal nerve is part of the sacral set of nerves, so nerves that come from the bottom portion of the spine. And the distribution of that nerve includes the vulva, so the outer part of the vagina, so the lips, and sometimes inside the vagina as well. So patients can feel pain, whether it be like a burning pain or a stinging pain, a sharp pain, but also sometimes some numbness as well. It can be exacerbated in certain positions, such as sitting, and it can really be impactful in their quality of life when it comes to sexual activity, things like that. So sometimes it's caused by a variety of things. So, it's important to kind of get a diagnosis. So when your doctor does your exam, or your pelvic floor physical therapist does your exam, they'll kind of get a sense of where's the distribution of the pain, kind of get that diagnosis. Working with the physical therapist, which Rachel can, kind of talk a little bit about, but can be very, very helpful. But sometimes doing certain trigger points, injections in that area can be helpful as well. And we do have urogynecologists as part of the comprehensive urogynecology program who do even sometimes some nerve regeneration techniques with that. So there can be some options.
When we see these patients, we like to take a look at where their pain is going, exactly as Dr. Smith is saying. What is your pain distribution and what can be contributing to it? We can treat patients a variety of ways internally, having some relaxation and some downgrading of those muscle responses, as well as treating the spine itself. The really nice thing about coming to all of us is we're physical therapists first who happen to specialize in the pelvic floor. So we can treat all aspects of what might be going on or what might be affecting your body. So we see a good number of patients who come in with this diagnosis and we have some really nice outcomes with them. It's definitely a comprehensive approach with the doctors and physical therapists, but we have some really nice outcomes.
Great. Well, thank you for diving into that for us. All right. Next question here from the audience. Rachel, this one's for you. Where are your PT offices located? And also, what is the success rate of PT versus surgery for uterine prolapse?
So our offices are the really nice thing about being part of, the whole Jefferson network is that we have offices downtown Philadelphia that see pelvic floor patients. We have the whole MOS network. There are therapists throughout the MOS network that also see pelvic floor patients. Through us here at Abington, we have a site at Warminster and then also here at Warrington. So it is a very specialized kind of niche area that people treat. And so there are a good number of us. We're just kind of spread out. But chances are there's someone in the Jefferson network nearby who would be happy to treat you. And then I believe the second part of the question was about the success rate of surgery versus prolapse. So we often will look at your symptoms as being our indicator of prolapse success. So we are not in the business of assuming we will downgrade your prolapse. Or if you're looking for like a reduction of grade, then that would be more of a medical approach. We are looking at more, what are your symptoms? So can we get the muscles around the area to help support and lift and downgrade your symptoms? So we're not, it's kind of looking at two different ways of treatment, if that makes sense. And
Yep.
Dr. Smith, you jump right in.
Yeah, no, totally agree. It depends on what you look at when you define success. And I also like to define success as symptoms, because sometimes I see patients who have pretty, a higher stage or grade of prolapse, and they're not bothered at all. Or if they've had a previous prolapse surgery, and then I can see a little bit of prolapse on my exam, but the patient's like, I feel nothing, that's still a success. So it really depends on what we define as success. So they're both great options for patients.
Yeah, absolutely. I like that definition of success can vary. So that's a great way to look at it. Okay. Next question here is for you, Dr. Smith. Can bladder prolapse be related to hypopigmentation of the vulva?
I will say no, it is not. Hypopigmentation of the vulva can be a very common condition, as well as so can prolapse. So sometimes we do see them together. They are treated differently. And one does not predispose to another, but they're very common conditions for someone to have, and they can coexist together.
Okay. All right. Thank you. Rachel, back to you for another question here. How likely is a recurrence of prolapse, and is 5 months of PT treatment enough?
So we often like to caution our patients to think of it more as a chronic condition. So prolapse, your symptoms can jump right back at you when you have had a coughing fit for 12 days in a row, whereas you've been symptom-free prior. So having the tools in your toolbox to help manage your symptoms is a really good way of starting. I would say 5 months of therapy without seeing you. If you were discharged and you met all your goals, then I would say yes, you and your therapist should be working together to formulate what are your goals, what are you hoping to get out of therapy. And if you were able to achieve those in 5 months, then that's awesome. Yeah. If you're able to achieve those in 2 visits, then great. It's always about what are your goals, what are your symptoms, and how can we help you functionally achieve these. So I would hope that you would have met your goals and were successful, and then the 5 months was a great timeline for you.
Okay, great. Thank you. All right. A question for both of you from the audience here. Are there any online resources you would recommend for at-home exercises?
It's a tough one.
Yes.
Without knowing the specific complaint that the individual is hear about, it'd be a hard thing for me to recommend. I know that there are excellent resources out there. Many are behind a paywall, some are free on YouTube. It really depends on what your individual presentation is. Again, some people doing strengthening is awesome. Some people doing strengthening will make everything a lot worse. So it's hard to give a blanket okay about any kind of exercise program without seeing the person in front of me.
Yeah, I feel the same way. Oftentimes I see a lot of overactive bladder specifically. When I do their exam, I'm assessing for things like high tone pelvic floor dysfunction, which I would not encourage that person to pursue a bunch of Kegel exercises without guidance. But if I don't identify anything like that, and I can teach the patient how to, you know, like I said, I'm not a physical therapist, but I can guide the patient through Kegel exercise during my exam. I'll talk to them about how they can use their pelvic floor muscles for urgency suppression when it comes to overactive bladder, as well as I feel like they're able to do pelvic floor exercises on my exam and they have stress incontinence. I give them a prescription. If they can't, if they're like, hey, I'm not going to go to a physical therapist, I still work on that with them in the future. But I do kind of give them a prescription. Well, I'll instruct them how many Kegel exercises to do throughout the day. And I give them a time frame, generally 6 weeks, because that's when I reassess them at that point. So I would say be cautious of online things without maybe an assessment first. But we do have some handouts that can be very helpful for patients.
All right. So overall, I think an expert first. So, all right. Okay. Next question here, Dr. Smith. This one's for you. Any advice you can provide on how to use diuretics safely while also dealing with incontinence?
Yes, it's very tricky. So diuretics are also known as water pills, and those are designed to make a patient produce more urine. So they work in a way that your kidneys will filter more and produce more urine, and they're used for conditions like volume overload. So who have leg swelling or who have heart conditions where they need to get excess fluid off, and it leaves the body through the urinary system. So symptom assessment is very important. So if a patient is telling me that, they're really bothered at nighttime because they wake up 5-6 times at night, maybe changing the time of day that they take their diuretic pill can be very helpful. I also during my assessment, I examine their lower extremities. So if they have a lot of swelling in their legs, I will tell them, in addition, like, do not stop your diuretic, that's prescribed for a reason, but doing, raising the legs at nighttime or using compression stockings can be very helpful. And I make sure that they're adhering to their fluid restrictions if they have any that's recommended by their cardiologist or their nephrologist. Sometimes beyond, sometimes medications can be helpful, but you got to be kind of careful with that. And some of our third line options can sometimes be helpful. Expectations are also very important when it comes to this because it can be a challenge to deal with, I'll say.
Okay. Thank you. All right. Next question here, Rachel. This person says, I've had the cystocele surgery with a rectocele. I know I need to start exercise. Where should I begin?
Without knowing how fresh out of surgery you are, again, hard to tell you where to start without knowing you in particular, but I would always go back to just nice, easy, deep breathing. Let your belly fill with air, let your pelvic floor relax, let everything kind of calm down. That's always a nice, safe space to start in. And then once you talk to your surgeon and you're cleared for activity, I would say come on over and see us.
Okay, great. Thank you. Next question here, Dr. Smith. Are you aware of any open clinical trials for Botox? Does Jefferson Urology offer Botox for uterine prolapse?
So Botox is not used for uterine prolapse or for prolapse, but it is FDA approved for overactive bladder, whether it be neurogenic overactive bladder or non-neurogenic overactive bladder. And we routinely do that in most of our offices. So it's a very common office-based procedure. We don't have any clinical trials with regards to Botox at this time, but we do have some clinical trials in our department with regards to urgency incontinence, and an implantable percutaneous tibial nerve stimulation device, which can be very helpful for some patients. We are actively recruiting patients for that trial. So you may hear from your doctor, if you are, if they think that you're a candidate, and it's something to consider for patients. So we do have some clinical trials with regards to overactive bladder.
Okay, thank you. All right, Rachel, question for you here. Is PT for pelvic floor a growing field? Are more PTs looking at certification or training for pelvic floor disorders?
I think so. I think every year we're seeing a little bit more certainly the younger PTs who are graduating more recently. They are going into the field, finding out what they love, starting to be in pelvic floor, and people like myself who have been in practice for a very long time who then come back to it as a found love. So I think the field is growing steadily. The rate of women who are now asking for prescriptions, certainly postpartum, post-surgical, going back to activity, seems to be growing as well. So I like to think that it's growing. I like to think that we're going to continue seeing really nice growth. I think it's the best part of PT. It's so fun and awesome, and I think everybody should do it. So I think we are on our way of getting it a little bit more accessible throughout everywhere.
Great. Great news there. Okay. Another question for you, Rachel. I have urinary incontinence, but I'm trying to stay active. And I was instructed that jumping rope, for instance, is not advised. This person is wondering, are there other specific exercises I should avoid at this time?
So it can be broken down kind of into your comfort level. So if you love jumping rope and jumping rope brings your heart joy and doing it for 10 minutes every day is the best thing for you, but you pee a little, some people are okay with that. If you would like to come in and be pee free, then we can certainly work on jumping towards that. I like to think that any loss of urine that you're not expecting is not okay. And so please come in and we'll help you solve that issue. But there should not be like this blanket statement of never doing something again. It's more about retraining your body into how it is absorbing these forces better so that then we're not losing the urine. And we actually have a really great evidence-based return to run or return to impact activity screen that we'll put our patients through so that we can really see based on exact muscle structure and function what's weak, what's not, why are you losing this urine as you're jumping, as you're running, as you're doing whatever. So I would say that I would probably hold off on anything that's making your symptoms worse until you see a therapist, unless it's the only thing that lets your brain shut off and you get stress relief. And then, do it mindful that you're going to have a little bit of extra leakage and then come on and see us and we'll get you to the point where you're not having that leakage.
Okay. Great. Thank you. All right. Know that we're almost at the top of the hour, but we'll go ahead and just take a few more questions here because I know we've been receiving a ton of live questions. So thank you all. This discussion has been great. So with that, I will continue. And Dr. Smith, we have a question for you here. Do hormonal changes have any impact on pelvic issues? Does starting menopause at an early age have any impact?
Great question. And I think someone did ask about pelvic floor and UTI. So this kind of ties into that. So around the age of menopause or after menopause, and menopause can start, I will say, naturally as a woman ages or sometimes be induced related to surgery or treatments, medications, like say for breast cancer or uterine cancer. And it can cause what's called the genitourinary syndrome of menopause. In particular, the vaginal and vulvar tissues get impacted because they no longer have the effects of estrogen. How can it be impactful? It can cause vaginal dryness, which can be painful when it comes to sexual activity. It's the number one reason why women around the age or after the age of menopause can have urinary tract infections. It can also cause urinary frequency and urgency. So it can really be a bother. And if someone has prolapse, let's say, their symptoms of prolapse can really be exacerbated when the vaginal tissues are, a little bit drier or irritated related to these menopause changes. So it can be, so yes, pelvic floor disorders can be related to menopause. Early menopause, can also, same thing, patients can experience the same kind of spectrum of symptoms. So genital urinary syndrome of menopause is becoming more widely talked about and appreciated. So yeah, that's a great question.
All right. Taking myself off mute there for a second. Thank you. Continuing here, here's a question for both of you. So whoever wants to chime in, feel free. Any advice for new moms who are healing post-birth?
Give yourself a little grace. You're keeping a human alive. Oh, you're doing great. Make sure that you're not giving yourself, a lot of pain when you're in and out of bed really quickly. Take a little bit of time, even when that baby's screaming, to get yourself a little bit more comfortable before you move. And we always encourage everyone to start small. Always, if you're very fresh postpartum and your bleeding gets worse as you're doing activity, you're probably doing a little bit too much. So give your body enough time to recover. We in the therapy realm tend to think of the recovery as a full 12 weeks physically. So even if you're not feeling 100% at that magical 6-week visit, that's okay. And just, it's awesome. It's so fun, but it's so challenging, and that's okay. If you need help, ask your providers for sure. That's why they're all there. But mainly congratulations. And we'll start seeing you whenever you want to come on in.
Yeah.
Right.
And to echo that as well, there's a time frame as well. So don't get discouraged if right away you don't bounce back. And working with a physical therapist can actually be very helpful with regards to future pregnancies as well. Whether it be if you have issues with incontinence or prolapse, it doesn't it's not that you shouldn't have future pregnancies, but working with a physical therapist can be very helpful at preventing or exacerbating this after future pregnancies.
Okay. Well, thank you both. And I do like that first piece of advice there, just giving yourself a little bit of grace. So thank you. Okay. Next question here for Dr. Smith. This person says, I've had internal radiation therapy. How long after should I be evaluated by a urologist?
Oh, I think I just kind of answered that in the chat. I typed out an answer, but that's a great question, especially with regards to pelvic radiation. There can be immediate and long-term sequela of radiation therapy. So more immediate, patients may have burning with urination. They may feel like they need to pee more frequently and may see some blood in the urine. And more long-term blood in the urine as well as the bladder can actually have some changes where it shrinks in size and can become more stiff. So I would say if you're having urinary symptoms after radiation, it's worth it to get checked out by a urologist to make sure that everything is okay. Sometimes reassurance can be very helpful. And certainly if you see blood in the urine, please see a urologist as well. Or radiation doctors are very attuned to the urinary side effects. So they may make some recommendations like medications, dietary changes. But if you're not getting better, then I would say certainly see a urologist. There's no too soon or too late to see a urologist. And again, I want to emphasize there can be long-term symptoms that come years after radiation. So if you're having symptoms, urinary symptoms, and you've had radiation, you certainly deserve to be checked out by a urologist or urogynecologist.
Absolutely. Okay, well, thank you. This question here, can spinal trauma or weak back muscles have an impact on the bladder and create issues like incontinence?
Yeah, great question. The bladder, as well as the bowel receives, as well as the vulva, and the pelvis in general receives nerve supply innervation from the spine. So certainly there can be the urinary system as well as sensation in the pelvis and bowel can be impacted with various spinal conditions. Sometimes it can be predictable, like in patients who have certain spinal cord injuries, but sometimes it's not. So patients who have things like multiple sclerosis, where they can have lesions in their brain and their spinal cord, it certainly is appropriate to meet with a urologist, because we actually do have guidelines for patients who have neurologic lower urinary tract symptoms. So we can make sure that they're safe, because sometimes bladder issues can actually impact the kidneys and can cause dangerous kidney conditions. So first and foremost, we protect the kidneys. And then secondly, work on improving your quality of life. So medications, certain lifestyle changes, sometimes a procedure may be necessary. But that's a great question. The spinal cord and issues with the nervous system can impact pelvic floor conditions.
Okay, thank you. All right, this next question here is for either one of you, so whoever wants to chime in. But this person's wondering, would the panel just mind quickly reviewing what trigger points are again? I know that we discussed that earlier in our discussion.
So trigger points are kind of pinpoint areas within the pelvis, pelvic floor, that can be painful to a patient. Sometimes when we do an exam, we may actually feel like a tightness in that area. So it can be something like a muscle within the pelvis, or sometimes it's kind of a nerve issue, or sometimes it's scar tissue. So really an exam is needed to identify what are someone's trigger points, because it can vary from patient to patient. And trigger point injections are treatments that involve injections of various medications, sometimes pain relieving medications, sometimes steroids, sometimes a combination of both, which can provide relief for trigger points. And sometimes it can be diagnostic as well, where if we inject that area and a patient gets better, it's like, well, maybe we think this is a nerve problem, or this is a muscle problem, things like that. So that's kind of what trigger points are, and they really differ from patient to patient.
Okay, super helpful. Thank you for kind of outlining that for us. Okay, Rachel, question for you. This person is wondering, how effective is physical therapy for stress incontinence?
We have really great success with our patients who are experiencing stress incontinence. We work a lot on the coordination, a lot on the correct use of the muscles in the area. And we always like to kind of dive into, are there bigger muscles that are also being affected? So why is the stress incontinence also happening when you're doing certain activities? For instance, like running or jumping. Perhaps how you're running and jumping can really impact that pelvis. A lot of the muscles that are connected in your hips, some are actually pelvic floor muscles that are rotators of the hip, and some also, you share a lot of the same nerves, a lot of the same muscle pathways that start in the body and then go down into the legs. So all of that affects each other and can affect the efficiency of the pelvic floor. So we'll take a look at why maybe other body systems are affecting that stress incontinence, and then hopefully by treating both together, we have really great outcomes.
Okay, thank you. All right, Dr. Smith, a question for you here. How effective, here we go. Is there any increased risk for cancer in using estrogen for treatment?
So that's a very good question. So when we talk about using estrogen, we are talking about using low dose topical vaginal estrogen, and it can come in various forms, like a cream or an ointment. It can come even as a ring that looks kind of like a diaphragm, or suppositories or tablets. And these are designed to work locally on the vaginal tissues. And that's different from systemic estrogen, whether it be a pill, a patch, injection, and those are designed to raise your blood estrogen levels and be estrogen replacements for patients who need hormone replacement for things like symptoms of menopause. There has been actually no association with using low dose topical vaginal estrogen when it comes to cancers in patients who have even a history of hormone sensitive cancers or who have a history of blood clots or strokes. However, certainly if I have a patient who has a history of any of those conditions, especially hormone sensitive cancers, I do check with their oncologist to see if they, if they're comfortable with using it. I also talk with the patient as well, because sometimes patients may say, hey, I hear you, but I don't want to be exposed. And we may do some non-hormonal treatments to treat their condition. But that's a great question. It's not, these formulations of estrogen are not designed to get into the bloodstream and raise the estrogen levels. But certainly talking with all of your doctors if that's something that's something that you're that we are concerned about.
Okay. Yeah, and I think that's great news to hear. So thank you. And a similar question here as a sort of follow-up. This person has said, how successful is prolapse surgery when a person is on estrogen suppression drugs after breast cancer? And is there an optimal window to have that surgery?
I'm sorry, can you repeat that question?
Yeah, absolutely. This person has said, how successful is prolapse surgery when a person is on estrogen suppression drugs after breast cancer? And this person is wondering, is there an optimal window to have that surgery?
So I will say the success rate is similar to anyone else who may not have a history of breast cancer or a history of estrogen suppression. When it comes to the optimal time to have surgery, certainly we work with the medical oncologist or the breast surgeon to make sure that there's no future treatments planned for the patient. But there can, really there's, no good time like the present, for the most part.
Absolutely. Okay, well, thank you. And I think we'll take about one or two more questions here, and then I have one final question before we wrap up for the evening. But okay, so this next question here, this could be for either one of you. Can uterine fibroid embolization be related to bladder prolapse? Does this procedure cause the uterus to shrink, and does that have an impact on bladder prolapse? So whoever wants to answer.
So I'll say it doesn't have an impact on bladder prolapse, uterine artery embolization can be a very successful minimally invasive treatment option for someone who has bothersome uterine fibroids. And yes, it is designed to shrink the fibroid because they can selectively, in most cases, kind of kill the blood supply to the fibroid, which will then cause it to shrink over time. It's not immediate, like as soon as you get it done, you're not a new woman, but over time it will shrink and reduce in size.
Okay. All right. Rachel, anything you'd like to add there?
No.
Otherwise, I think we can go to our last live question for the evening. Dr. Smith, can you talk a little bit about devices that are inserted to stimulate muscles? Are they effective?
So that is a great question, of which we don't actually know. So there's many reviews out there that are comparing, looking at these devices, and they're fairly kind of new, and there's a lot of direct to consumer marketing. The studies so far show that these devices are probably better than not doing anything at all, but the jury is out whether or not these devices are more effective than physical therapy. So we don't know that answer. Hopefully soon in the future, we'll have great trials that will give us that answer. I certainly hope that it can be a good option for patients to use as an adjunct, maybe to physical therapy. But from the data that I've seen, I would say it's still out. Maybe Rachel has some thoughts about that.
I think that a lot of what we've seen, again, the studies are not out there yet to show efficacy, but things that are very, very passive tend to not be that effective, since our bodies are not passive, and you won't be able to, say, sit on a chair that has you contract your pelvic floor when you need it to. And things that can be inserted in the vaginal canal or rectal canal, depending on what your complaints are. A lot of them will show an uptick in the muscles, but they won't show that relaxation. So it can be a similar issue where you're not knowing, am I getting a full contraction and full relaxation, or am I just contracting this muscle over and over and over again without a full relaxation? So we're kind of waiting on the data as well.
All right. Well, thank you both. And thank you to the audience. Just such a terrific discussion tonight. A lot of great questions. So I have one last question before we wrap up for the evening. And that is, what would you like attendees to take away from this webinar? So Rachel, we'll go ahead and start with you.
Sure. I would love for everybody to take away that, though it's not a one size fits all approach for any of our patients. Everyone comes in with such a unique complaint set, as well as a unique body presentation, and we take it all into consideration. So it's never a one size fits all thing here. I love how many people attended and had such great discussions. I want to encourage everybody to remember, just because something is common doesn't mean it's normal. And if you're having something that's affecting your daily life, certainly talk to your provider about it, and let's find a way to have your symptoms become a little bit more easy to live with, and certainly ideally go away completely. So, we encourage you to make an appointment, come on in. The first step is often the hardest, is to call and actually make an appointment. But we have providers throughout the area, downtown, here at Abington, throughout the Moss network, that would love to treat you and talk to you and help you get to all your goals.
All right. Well, thank you. And Dr. Smith, any final remarks from you?
Yes. So Rachel and I are we are representatives of a much bigger comprehensive group. So there are urologists, there are urogynecologists, minimally invasive gynecologists, physical therapists. We also work with colorectal surgeons, as well as some general surgeons. So it's not a one size fits all for everyone. And we have pretty much everything covered at Jefferson. In addition, these pelvic floor disorders commonly go together. So someone will have prolapse, they will have incontinence, they may have constipation. So someone may need to try multiple treatments to get them to where they need to be. So I would say don't get discouraged. Keep working with your doctor, and keep asking the great questions that like patients have asked today, because education is important.
Absolutely. Keep asking those questions. So thank you both. We really appreciate your time this evening. I know a lot of great information was shared about pelvic floor disorders and incontinence. So thank you, Dr. Smith, and thank you, Rachel, for your time. And thank you all for attending and submitting your questions. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Are there any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And we do have more wellness webinars coming up soon. So if any topic is of interest to you, be sure to sign up. A recording of this event will also be sent to you so you can rewatch. And if you'd like to view other wellness webinar series events, please visit our Jefferson Health YouTube channel at youtube.com/Jefferson Hospital. We have everything from back and neck pain to robotic surgery to planning for pregnancy age-friendly care, and much, much more. Well, if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Thank you.